always grateful to that. I was the chair of OBGYN in Basel, and then 12 years of the University Hospital in Bonn. I'm now retired from that at the age of 70, but I took up another job as the chair of the healthcare management program in St. Gallen at the University of St. Gallen in Switzerland, which is very good in management, economics. And I think many topics we deal with have the medical aspect and the economic ones. Ideally, we would have the highest quality treatment and at the same time trying to save money to keep our healthcare system affordable. I think that is also a very important task. So speaking about NIPT, which I've done here before, always enables us to give an update in the sense that we ask exactly this question: what has been the impact in the world? And I give tribute here to Professor Diana Bianchi, who many of you know. After her time in Boston, she became the director of the National Institute of Child Health and Development, named after Eunice Shriver Kennedy. And she has collected data from all around the world. This is pretty recent data, even though she's no longer in office. There are all these changes in the United States. But she tried to figure out what has been the impact of the non-invasive prenatal testing on the usage of amniocentesis and CVS. These are procedures, they cost money, they have a risk, and it came out that internationally the best possible estimate from the data is 70% reduction. And this is really significant. I mean, let's think about it. How many procedures do we have that, you know, are replaced by something non-invasive, non-risky procedure, and the impact that has. So some people predicted that, but now we know for sure. So this is, I think, a very important new piece of information. And regarding the risk of amniocentesis or CVS, we all think that in our hands, and I see Jolie Simpson, he has done 10,000s of procedures, myself, many others here. We always think we are so safe, but let's quickly look at that. When CVS was introduced, middle of the 80s, they did the proper thing. They did 4 big randomized studies, probably difficult to repeat. 50% of those women who wanted CVS got amniocentesis, and then they could compare the total loss rate. Here you see the results. 1 Canadian study, 3 Scandinavian ones. The Scandinavian ones didn't show a difference between amnio and CVS. This is counting all the pregnancies where a heart rate was detected early and then seeing how many ended in a live birth. The European multi-center study conducted by the Medical Research Council showed a significant difference to the disadvantage of CVS. But the explanation is that in the Scandinavian and the Canadian study, these were experienced investigators. In the multi-center trial, 40 places participated. Probably there were many who were not very trained. So what this shows us is that CVS nowadays, in experienced hands, is equally safe than amniocentesis. But remember, the best study on amniocentesis by Ann Tabor also showed a risk up to 1%. It will never be 0. So 70% reduction of these procedures is a great achievement. What did it do to screening in pregnancy? I think we have 4 quite established methods of screening now. There is the ultrasound screening. This will never be replaced because some structural anomalies you won't pick up by any other method than by ultrasound. We have the classical screening using biochemical markers. And clearly, nowadays, CVS by far is the best screening procedure. And I'm quite impressed by the data. We also worked on it. It took a long time, but also prediction of preeclampsia is getting much better. But regarding the screening for aneuploidies, remember when we just looked at the maternal age and said 35 years is kind of a cutoff, we detected 50% of trisomies 21. with a false positive rate. At that time, 20% were above 35 in Germany. So this was a bad performance. We didn't have anything better. Then biochemistry came, it improved the detection rate, the false positive rate went down, combining it with nuclear translucency even improved it further. But now, and I will show you the most recent data, a 99% detection rate for a false positive rate, which of course frightens women, but only far less than 1%. So this is a great development. This is data, combined data from the performance of NIPT nowadays, 99.7% for trisomy 21. You can read for yourself for the next three other aneuploidies. And the false positive rate, this is a real achievement, is way below 1%. And here I can show you the data from our own study in Germany, and it was pretty much the same as what Diana Bianchi showed, that the reduction in Germany of amniocentesis was also exactly 60%. So this is confirmed now in many countries. But as I said, and I want to underline it, ultrasound will never be replaced. And this was brought home very much by the study of Cassie Bilardo, who showed that depending on the size of the nuclear translucency, let's say you are between 3.5 and 5 millimeters, you have 11% structural defects, and only a fraction of those are caused by chromosomal abnormalities. So this is my first update on CVS, on NIPT. But the second thing I always like to do is to take this development as an example of what you can learn. It started for us more than 30 years ago. This was using Y probes and showing, yes, there is fetal material in the maternal circulation. This was the idea to use NIPT based on fetal cells, that we would like to isolate them at that time from the maternal circulation. Then this NIH study was conducted. Jodie Simpson was part of that, our center as well. Again, a comparison to the results of amniocentesis. And the conclusion was, read the last sentence here, they help us to learn about the material in the blood. They have allowed us to do diagnosis. Jolie and Elias did the very first of a trisomy 21. But the conclusion was the recovery is too difficult, not clinically practical. There are errors in prenatal diagnosis. You don't want an error kind of sitting on the wrong horse here. And then I think we have to give big credit to a person who was reading in other fields. He was reading work of Anker and Stroon, geneticists from Geneva. They had shown cell-free DNA in the fluid of plants, a completely different area. And then they realized, yes, this could be the case in pregnancy, that there is cell-free DNA. And then the technique was developed, which is straightforward, isolating, amplifying of the material, and then using next generation sequencing. In the beginning was using the Z-cores, now AI is used for that. And this makes the diagnosis so safe. There were 2 randomized studies done early, very important. NIPT was really introduced during the proper studies at the proper time. So I think this is something we would like to see in all areas of medicine. And then the national and international organizations can come in and say, yeah, this is standard now, this should be offered to every woman. Science picked up on that and said, this is very important. Dennis Lowe got the Lasker Award. I hope he will get the Nobel Prize. So this is about chromosomes. Chromosomes are very safely found now by NIPT. What about single gene anomalies? And we have to realize that at the time of birth, 2 to 4% children have some problems. And the aneuploidies, trisomy 21 and so on, is only a quarter. Single gene anomalies are rare by themselves, but in aggregate, they are frequent enough. And also in the group of the structural heart anomalies, there are some that have genetic single gene origins. So let's quickly go through that, because again, it is a perfect example of how fields can develop. The first application was rhesus. You see sensitivity and specificity especially very high. What about autosomal dominant diseases? You can diagnose them easily. If the father carries the mutation, 50% of the children will be affected. So if you find non-invasively the paternal mutation, the baby will not be affected. What about autosomal recessive diseases? Should be difficult because the mother also carries the gene, like the father, 25% recurrence risk. We took thalassemia because it's so frequent in the Mediterranean region, but also in Germany. Nowadays, we have a lot of thalassemias, and there it helps that the mutations can be so different. So often you have compound heterozygous. Father has a mutation, the mother, and there's a 25% risk for the child. And this we could diagnose. This was our first paper on that in JAMA. The technique was a little bit modified over the time, but nowadays it's pretty safe to diagnose single gene diseases using NIPT. The interesting thing is that if something works so well, and this is also a new development, then and is protected by patents, there are people coming up who say that they have a contribution to this technology. So I was asked to be an expert witness at a trial where somebody claimed that by using special tubes you increase the likelihood of diagnosis. And we had shown that it doesn't work. Other groups had also contradicted it. But he put in a claim for 140 million. He only got 50 million, as you can read here, and I thought maybe we were not convincing to the jury, but the market reacted by increasing the value of the company, Natera in this case, who offers the tests. So it shows you that we have reached a situation in medicine where commercial companies who take over something, they have to be prepared for some people attacking them. The non-chromosomal ones, the non-trisomy diagnoses, of course, are not age-dependent. So you see the red line here over the age range. The others, the genetic ones, of course, are not age-dependent. So, of course, the question comes up, what should we offer to women independent from the age with regard to non-invasive prenatal diagnosis? And I just want to illustrate with this slide that the list is increasing all the time. So we have to be aware, we have to know which diseases can be diagnosed and which cannot. But I think it's a fantastic development that there are more of those coming up. However, what at the same time we should know is what else we can do with these diseases. And I take the example of spinal muscular atrophy. You know this disease, the babies are born, they look normal, and then they have a deterioration, a very bad one, neurologic deterioration. So nowadays you can do carrier screening. You don't have to wait for the first child. You can do it on the prospective parents. If they have a pregnancy, Jolie speaks about it, you can even, in the context of productive technologies, do testing. And then you know before there are symptoms in the child. And at the same time, techniques were developed to treat the disease. If you are early enough, you can use oligonucleotides all the way up to gene replacement therapy. Some of these therapies are quite expensive. But it means that an untreatable disease, where prenatal diagnosis was just a search and destroy mission, nowadays is more complicated in counseling because you have to speak about the options of treatment if you have the knowledge in time. And non-invasive prenatal diagnosis can provide this knowledge in time. And of course, at the horizon is whole genome sequencing. It has been done also in the context of NIPT. It creates the same problems as it does with MNEO or CVS, that you get so much information, variance, and so on, that the counseling becomes very complicated. I want to finish by mentioning that nowadays the non-invasive approach, of course, can also be used for other things. And I come back to Diana Bianchi. One of her last papers when she was still with NICHD was on using cell-free DNA for detecting even predispositions for cancers prenatally. So this is amazing, but it's logical in a way that if there are genetically determined predispositions, you would detect them. And so I conclude by saying that this technique, non-invasive technique, has spread to other areas, from the prenatal diagnosis to even pre-implantation diagnosis, to detecting predispositions for diseases. And it was a great pleasure. I was asked to give this Zeppele lecture at FIGO, and one of my students is now the president of FIGO, Frank Louven. And this shows how well connected the different areas of obstetrics and gynecology are. A new technique has applications in the different fields. And this is the reason, of course, that OBGYN is the most exciting field you ever could get to in medicine. Thank you very much.